Thank you very much for attending this session. We had over 500 participants today. And I know we had some IT issues, but well, that happened. We hope to have this yearly event in person next year, but if not, who knows? Maybe we'll do it virtual again. So what have we learned? Well, I hope that you will be able to download the Smart DM2. This is an Emory app. This was developed for you, and we are expanding this to be used all around the world. I think it works well. Try, use it with your students and residents, and please let me know. And I will not take it personally if you don't like it or you have suggestions or errors that maybe we have missed. This is something that we were planning to expand not only for the outpatient but also for the inpatient setting. In reference to the first session, the treatment of type 2 diabetes, I think it was superb. Both Sol and Priya did this review on non-insulin and insulin management. I loved the question. There were over 100 questions in that session. And of course, they really touch on the most important aspect that we still use metformin as a first-line agent, that in some patients, other agents may be used. The use of sulfonylurea is still widely used, but it should be used less and less in the future in the way that they are associated with hypoglycemia. If we will have all the medicine that we have for diabetes care with the same cost, let's say $5 each one of them, I think we will not be using sulfonylurea as much. I think our primary care providers should consider to continue to use metformin as first-line agents, but use medication not associated with hypoglycemia, both in the outpatient and in the inpatient settings. With respect to insulin, I think basal insulin analogs should be preferred over NPAs and 70-30 insulin. However, in some circumstances, due to financial constraint, the 70-30 of NPAs can be used because they are as effective in improving glycemic control, but again, they have more hypoglycemia. When do we use the new insulin? Well, in those patients at a high risk of hypoglycemia, and they will allow flexibility. Of course, they are a little more costly, and all depends on the insurance covers that the patient may have. In the second session, we heard about Dr. Pascal talking about the cardiorenal protection. And this has been the major difference in the last year. And I'm the chair of the ACE guidelines, and we are now going to recommend that for those patients who have cardiovascular disease, to consider using GLP-1 and SGLT2 independent of glycemic control. So if you have a patient with 7.1, 7.2 hemoglobin A1C or metformin, those agents that have cardiovascular disease should be considered. The other point that I believe is extremely important to take in and to remember is that if the patient have heart failure, the use of SGLT2 has been shown, especially if they have low ejection fraction, the SGLT2 has been shown to reduce admission to the hospital and more importantly, reduce mortality by 20%. That is why the FDA a few months ago approved the use of SGLT2 in patient dapagliflozin for patients with and without diabetes. This is a medication that our cardiology friends are learning to use. They do not produce hypoglycemia, and nothing should be used in most patients, especially with diabetes. And Dr. Davis discussed about the use of technology. That's right. This is a point that we would love to see our primary care doctors to use more and more CGM, especially for patients with type 1 diabetes. About half of the patients with type 1 diabetes in the United States are treated by primary care. So I think that the use of CGM in this patient has been shown to improve glycemic control and facilitate and give the patients the knowledge of how glucose control they're doing. For high-risk patients with type 2 may also benefit from CGM, and the use of insulin pump has been around now for over 20 years and now is increasing. We can help you with the diabetes management program We can help you guiding this patient with insulin pump and connect the insulin pump to the CGM, what we call artificial pancreas or closed loop technology that is increasingly used in patients with type 1 diabetes. Again, I want to say thank you to all of you for participating in this session today. I hope that you learned. I did learn a lot from, and more importantly, thank you for the questions and your participation. And I appreciate the input from IT and the Continuous Medical Office, the Continuous Medical Education's Office for supporting this program. Thank you. We'll see you around. Goodbye.